promotion at prevention through to treatment, rehabilitation, palliative care, and across the life course of the person. And so today, discussing universal health coverage, and we are discussing how we can amplify survivor voices against breast cancer. I have 4 panelists that are going to be taking us through various aspects of survivorship, cancer care, cancer control, and advocacy for us to be able to define. Yes, it's the last in the series of 4, but it's the start of the life beyond the October Awareness Month. How can we take the conversation on breast cancer forward, even beyond the Breast Cancer Awareness Month? We will be having with us today Dr. Esther Mwinga, who is a coordinator of pain relief and palliative care. She's a medical officer in the Ministry of Health and serves full-time as a pain relief coordinator and palliative care coordinator, seconded to KEPCA, the Kenya Hospices and Palliative Care Association, and she's currently supporting the Ministry of Health and KEPCA to integrate palliative care services in county hospitals in Kenya, working to improve availability of essential pain medicines, including oral morphine, and to scale up clinical training, updating of policies, integrating of palliative care, and with technical support from the Treat the Pain team. She'll tell us more about Treat the Pain. We also have Christine Mugositati. Christine is the Executive Director of KENCO, and she is a results-driven advocate with approximately 14 years of experience in health and nutrition programming within the NGO sector. She's also the country champion for the Cancer Advocates Program from the UICC, that's a Union for Cancer Control, UICC, as well as the Hub Coordinator Africa Cancer Research ECHO within KENCO that hosts the ECHO. And she's results-driven, and we will get to learn more about the advocacy in civil society that is happening currently. We are also joined by Deborah Ikonge Bitange. She's a technical advisor and health system strengthening at Ministry of Health, public health expert with a master's degree in health economics and policy, over 10 years experience driving and implementing the implementation of health programs in the public sector, as well as projects in disease control and elimination. She's also very passionate about building resilient health systems with a focus to health financing and primary health care, and also enjoys continuous learning and making continuous professional connections. Lastly, we have Lucy Njeri, who is a health systems advocate and a cancer advocate, championing working with healthcare systems that facilitate timely, affordable access to treatment for cancer survivors for improvement in quality of life and better survivorship. She also empowers self-advocacy by creating awareness and sensitizing at the community level, and she's a facilitator with Mizizi under the Fresh chapter on emotional healing. As I've said, today is going to be quite interesting for us. And to start us off, because we are starting with talking about survivorship and how we can amplify survivor voices against breast cancer, I would like to invite our first speaker, who is Njeri, to share within 5 to 7 minutes her experience. Njeri, if you can tell us about your experience regarding what you experienced, regarding the cost of care, and what you wish every patient or family knew about breast cancer and cancer in general. Over to you, Njeri.
Good afternoon, and thank you very much, Brenda. I'm humbled to be in this forum, amplifying the voices against breast cancer and survivorship, and looking at cancer at large, because it's not only that breast cancer that affects us, but different types of cancers. First and foremost, I got my treatment here in Kenya. That was the year 2017. And I had very few hurdles, because by then NHIF was covering almost everything. So financially, for my chemo and my radio and my surgery, there was a bit of relief. apart from the radiologist when you go to do the what do you call them? The scans, and maybe the blood work and consultation. So by then it was much better, but as of now, things have really changed. There's a lot of improvement, and there's also a lot of downside from the NHIF. And there's a lot of improvement on creating awareness, because we as survivors took the initiative of letting people know about the cancer, and we've been infected by it. And we stood boldly and very vulnerable and shared our stories in platforms for people who dared to listen, to give us audience. We talked about awareness and screening. And as we speak now, I'm glad that screening has been taking place and we've reached so many people. So as you know right now, the number of cases of cancers have risen up. I give credit to screening because they are readily available. Apart from that, watu wako huko mashinani, it is not only in the city centers or in towns and cities. So people have gone huko mashinani and screening is being done, and people have been caught. That is why there's a rise in the number of cancer cases as opposed to before, when screening only took place in maybe a hospital setting and only in big hospitals. So I accredit that for the awareness we have created. But then there's a challenge. Oh yes, we've got them and here they are. Are we able to put them in the health system? Are they able to access the health care that is there, that they need at that very particular moment? Do they have the funds to do their biopsies and their immunohistochemistry? That goes to diagnostic. It is at bottleneck, because here I am, I've been caught, I have cancer at stage 1. I need to do biopsy, it is out of pocket. I need to do immunohistochemistry, it is out of pocket. No doctor will touch me before I have that at hand. And if you look at the cost, it's skyrocketing. So you find that when I go back to look for the money, or the patients go back to look for the money, by the time they're coming back after 3 months or 4 months, it has escalated to another stage. So I have a vague question. I don't know who probably could have the answer to that. Why do we pay so much for the treatment when I'm in stage 4 and stage 3, and you cannot pay for me 40,000 for diagnostic, for the investigation to start? I think it will be very, very, it will make logic when we have the biopsies and the immunohistochemistry paid for by NHIF, and we start treatment immediately. And after we start treatment, the stages of the cancers that are being caught early could be arrested early. Secondly, probably it's the information. Do our patients have the right information? We don't have the right information. And where are we supposed to get that information? I think there's a scarcity in that. The other day I went to talk to somebody and they said that they wanted their breast preserved. And I told them, we are doing breast preservation as per now. You don't have to go through total mastectomy as I did. When she went, she was told that you need to pay for the ring and the pin. And she called me back and she told me, Jerry said that this thing is there. And I said, yes, it is there. But I didn't know that if you need to do preservation, there's a process where you have a ring, or there are markers that are done on the patient, so that even after chemo and the mass is dissolved, the doctors will know where it was. My patient could not have that amount of money. So as much as she wants her breast conserved, we are going to miss her somewhere, or it won't be conserved, because she has not been able to raise the money for the markers and the rings. Secondly, the use of survivors as key to prevention. I think we are the link. For us, we have a lived experience. And for us, we have the feedback to the treatment that is being offered in Kenya, and for our doctors that are working on us. Because definitely we are the specimen. When he took this medication and administered to me, this is how it took me. So when I'm back, Daktari, these were the side effects, or these were my feelings during this time. Are we given that audience to tell the Daktari, or the Daktaris that we are having, they just look at you like this, continue speaking, and then they write, and then they give you go to the next room. That is something that is happening. At least we pay for consultation fee. Listen to our patients. We have something to say. We have a feedback for you, all for our good and the good for the rest. And then for us, if you get somebody there who has a diagnosis, the easiest way to align that person with treatment is to link them with somebody who has a lived experience. They'll tell that person, kwa mapana na marefu, it is a difficult journey. And it is. There's no cosmetic, and there's nothing good about cancer anyway. As much as we do so much, it's a difficult journey, and you're going to go that journey alone. And the feelings that are coming, and the challenges that are coming, and the pain that are coming, it is you to face alone. But then how do I face them? I've not been equipped, I've not been informed, and I don't have a linkage. So for me, I feel that somehow, somewhere, we are still not getting it. We are still missing up. And for us, we do it voluntarily. Yeah, you just call me, call the other person, link them, and we do it voluntarily. And when we are doing that, we are doing it for the good of the community. But then if there is a chance for us to be integrated and get jobs and get a stipend out of what we are doing, we would appreciate more. Everybody wants to have another piece of bread on the table. Everybody wants to be happy with what they are doing. We have been doing this voluntarily for the last 7 years, but if I stood up and said, this time round, please cater for this and this and this, the thing is that we don't have a budget for you. So where do we fall? Where are we? Or whatever are we doing? Is it matching or is it losing? Thank you.
Thank you. There is much to be talked about today. And I think you've started us off on the right footing to understand that for you, NHIF did serve you, and that there is opportunity for improvements in even how continued service from the health system is serving survivors as agents of change in the community. And I appreciate that you've raised a number of things, including challenges that you're facing as survivors. And so that we can have a whole continuum understanding of the challenges in the healthcare system, the gaps and opportunities that present themselves, I would like to invite Dr. Esther Mwinga, who will speak into the challenges that she's seen from palliative care across the pain management, across the continuum of care. What are the gaps and the opportunities that we have that we can be able to work with survivors, work with the healthcare system to improve? Not that we're not going to address the questions that Jerry has, but I'm pretty sure that because we have quite a number of experienced panelists, they'll also be able to pick up on some of the things that Jerry has raised. So over to you, Esther. Dr. Mwinga, you're muted. Thank you.
Thanks, Brenda. Let me share my screen. Or Nelson, if you're able to from your end.
Hey, Nelson, are you able to help with the display for the screen? As we're waiting for Esther's screen to be put up, Nelson, are you able to assist? As we're waiting for Esther's, maybe we can go to Christine. And Christine, maybe you can speak into what KenCo is doing in terms of patient support groups, in terms of bridging some of the gaps Jerry has raised, and also what advocacy gains you've seen within the last couple of years that would lead us to think there is light at the end of the tunnel. Christine. Oh, sorry. Yes, Christine, go ahead.
Okay, thank you very much, Benda, and of course, Lucy, for going ahead of me. It's really a pleasure to be speaking in today's meeting. So I'm speaking to what the Kenyan Network of Cancer Organization does, and in line with what Lucy, the perspective that Lucy has given us from a patient's viewpoint. So just to introduce who KENCO is, I think I need to put this on slideshow. Yes, so KENCO is a national umbrella body for cancer civil society organizations that are spread across the country. And we all come together for a united response against cancer. Currently, we are talking of about 60 plus minus 5, so about 60 organizations that are dealing with different aspects of cancer, right from cancer education all the way to survivorship, the whole continuum of care. And we have come together for one reason, just to have one approach as we deal with cancer. And KENCO is registered by the NGO Coordination Board. So our vision as an organization is we envision communities and people that are happy, healthy, and they have hopeful lives despite the cancer challenge. Our mission, we exist to promote health equity for all people that are at risk or those that are living with cancer. And we do this by influencing the healthcare systems, raising awareness, policy education and advocacy, partnerships, and targeted research. Our core values are integrity, equity, teamwork and partnerships, diversity and inclusivity, just ensuring we leave no one behind. Now, I spoke to our members. So these are either NGOs, they can be community-based organizations, trusts, foundations, societies, or patient support groups, as long as it's an organization that is registered and they are working in cancer control, then we encourage them to join the umbrella body. So in terms of the services that we offer, not just for breast cancer alone, but in terms of, all cancers, whether adult cancers or childhood cancers, it's across the whole continuum. So our members, they are those that will be doing education. This is to create awareness on the cancers that are there, the risk factors, and how somebody should be living, the healthy lifestyles, and what to look out for, so that, just to create demand for screening services. Then there is the screening bit. Lucy mentioned this. So we encourage people, like for breast cancer, we have the national screening guidelines. And it's very clear about the screening for breast cancer, the ages, and what type of screening a woman should undergo, depending with their age. So we teach this to our members, we sensitize the members, and they go out there and sensitize community members. There's patient navigation that is offered. As members do the screening, there's navigation across the healthcare system so that we are not losing any patient along the way. There's treatment support. Again, this has been mentioned. So our members will look into NHIF support. If it's the children, we have a member who ensures that any child who comes up with cancer, then they are covered by NHIF and they're able to access treatment. If it's the adults, we have organizations that will support NHIF cover for different patients. There's treatment funds. There are those organizations that will support treatment over and above the NHIF. Then there's the indirect costs. I think Lucy again has talked about this. Over and above a patient's treatment, the treatment costs that are there, if it's surgery, chemo, there are these other added costs that come. For example, accommodation, where with the patient be staying at their caregiver, issues of food, there's blood donation, then all these other tests that come along the way that are not covered by the national insurer. So somebody needs to take care of this. And KENCO members, some of them take care of this, although not completely, and it's still an advocacy issue. There's psychosocial support, which I believe most of our members do. Just taking care of caregivers and patients that are undergoing cancer. Palliative care, we'll hear more from, I'm sure, from Dr. Mwinga. There's rehabilitative commodities. So in the case of breast cancer, where there's the knitting of breast prostheses and the distribution of the same, both by KENCO and its members, just to ensure that, women dignity has been restored. Sometimes we get donations for silicone prostheses, so we also donate that. We're also working with a company that has been donating hair wigs. So this is where a woman has undergone chemo and they've lost their hair. We are able to donate a wig, and their self-esteem is restored in terms, they are looking good and all. Then there's survivorship. We also have a member who's doing this. And it's very important to integrate back survivors into the society. It's not the end. Having a cancer diagnosis is not the end. And there's much more that survivors can do, both in creating hope and also in their lives. Now, Lucy spoke into some of the gaps that are there in breast cancer control and cancer control in general. So in our strategic plan, the new one that we have, we are looking at identifying and strengthening programs and patient voices to reduce the impact of cancer. So issues of safeguarding for patients and beneficiaries, having a benevolent fund to continue some of the work that we are currently doing, health system strengthening in terms of the trainings for healthcare workers to increase their suspicion index. If a woman shows up in hospital with a lump, they have a right to ask for further tests and all. Creating of awareness, psychosocial support, legal aid, where, women lose, families, or they are discriminated against, property goes, they lose their jobs. So we are looking into supporting that. Then there's influencing the realization of a very receptive and effective, inclusive infrastructure in Kenya. So I know Benda alluded into this policy advocacy, budgets, issues of the syntax, government collecting this and sending it back into healthcare systems, and a human rights-based approach. Then promoting socially protected incidental environments, just to ensure that our environment, there's the hot debate of pesticides, the type of foods that we are eating, the kind of environments, all this discussion about dump sites. We need homegrown research that can show, how our body is reacting to all these and what needs to be done about it, and sharing the same out there for policymakers to make, evidence-based decision-making. Then, of course, strengthening KENCO as an umbrella body. There are so many organizations out there that are doing so much, but some are not known, and patients need to know about them so that we have that, united front when dealing with cancer. It's not a one-man show. It requires a lot of multi-sectoral approach. Everybody can play a role, regardless of what you do and where you are. So those are just some of the activities which I've already mentioned. So maybe just in terms of awareness, we celebrate all the health days and the cancer months. Each month there is a cancer. Most people know about October month, which is breast cancer month, but every month has a cancer to commemorate and to support. Health system strengthening, I talked about the healthcare workers training. Then there's the cancer education materials for patients and caregivers, where we distribute materials for newly diagnosed patients, including breast cancer patients, and they are able to be, health workers are trained on how to break bad news and how to take the patients through, what to expect through the treatment journey. There's policy advocacy. KENCO is represented in all the Ministry of Health technical working groups at the National Cancer Control Program, just to ensure that as documents are being made, there's a patient voice represented. We are happy there's a breast cancer action plan for the country, which is really elaborate on what needs to be done in the areas of breast cancer. Then, of course, all other supporting documents, like now we have a new National Cancer Control strategy. We have a cancer policy in place, the screening guidelines, and very many other guidelines that are around cancer control in the country. We have been in the forefront on advocating for health financing. Lucy has really spoken into this. A lot of the funds are going into treatment, but what if we change the approach and looked at, screening and diagnostics, which are not covered, where patients are spending so much money, especially diagnostics, and they end up disappearing and coming back when the cancer has really progressed. There is access to essential cancer medicines. We are happy, for example, now Herceptin is it's currently free in all government facilities for all the 18 sessions. So if we could have more of this medication, I know currently 23 drugs are free. What if we could have more? We have about 100 of them, essential medicines for cancer. What if we could have more? So it's an advocacy issue, access to cancer diagnostics. There's research that we've continued to do, investment cases, and various other types of researches which we are looking into just to empower the general public. We run an African Cancer Research and Control Echo, where we are able to share information on a monthly basis across Africa with different practitioners. Then, of course, patient support. So the rehabilitative commodities, sometimes it's food, sometimes it's, depending with the kind of need that the patient has, we are open to discussion. So that is what we've been doing, not just for breast cancer, but cancer in general. And we are open to have discussions on how best to support the patient. So that's just a brief on what we are doing. Sorry. And yes, over to you, Benda, for more discussions. Thank you.
Thank you so much, Christine. And I think you've touched on very pertinent issues around how civil society, when we all join our voices together, can be able to amplify the voices of survivors, the voices in the healthcare system, so that we can be able to advocate, to raise awareness, to raise knowledge, and to bring services close to the people. And so I want to go back to Esther Muinga to see if your slides are up now. And yes, kindly, Esther, take us through.
Thank you. Thank you so much, Benda. Thank you, Nelson. If you could put it on slideshow. So building on the, yes, thank you. That's clear. So building on what has already been shared by the two previous speakers, I'll be looking at the aspect of palliative care and survivorship, which is part of this continuum of care as we're looking at diabetes, as you're looking at cancer and support for the patients and the family. So I work with an organization called Kenya Hospices and Palliative Care Association, which is the overarching body for palliative care services in Kenya. And we work in close collaboration with the Ministry of Health, other civil societies to ensure that we have quality palliative care for all in Kenya. So in terms of defining palliative care, we are really looking at an approach that improves the quality of life of patients and their families. And that's the key point we need to remember as we go through this discussion. Looking at the aspects of relieving and diagnosing whatever suffering they may be going through. It could be physical, psychosocial, or spiritual needs. And the term palliative care comes from the Latin word pallium, which just means to cloak. And the reason we are talking about improving the quality of life is we are looking at taking care of the patient's symptoms or mitigating the suffering that the patient has. So it might not be necessarily effecting cure, but
We lost Esther to the call. Esther, are you still on? Okay, it does seem like Esther is having challenges with the technology. And even as we're waiting for Esther, we do have one other speaker who is Deborah. And Deborah Bitange is a technical advisor with the Ministry of Health, especially on health financing and health system strengthening. And so maybe as we're waiting for Esther to rejoin the call, Deborah, you can come on and actually help us understand.
they might be.
Sorry. Esther, we lost you for a second.
Is it back?
Esther, we lost you for a bit. Yes, we lost you at the point where you were speaking about where palliative care, the word comes from.
Sorry. Oh, thank you, Benda. So I'll
Yes,
go back
go
on
right
that
ahead.
one.
Go
Palliative
right
care
ahead.
really looks at clocking. So we might not be affecting. Okay, thank you. We might not be affecting cure, but we are looking at mitigating the suffering the patient might be going through. So this is applicable through the continuum of care. Next slide. Palliative care begins from the time of diagnosis. So for our patient with a diagnosis of breast cancer or any other life-threatening illness or serious health suffering, so it could be very many possibilities. From the time the doctor gives you this diagnosis, there might be curative therapies being given to you by the primary doctor, but then palliative care services are also provided at that point. So if we look at the image on your screen, you'll realize that sometimes a diagnosis might be curable. So the medications are given and the patient is remission, they're okay. But sometimes it might not be. So as time goes by, they may receive more palliative care than curative therapies. Palliative care goes beyond the loss of a patient, because the family who's left behind, who are part of this palliative care journey, we need bereavement support, and palliative care does come in to support them at that point. Next slide. We are looking at different aspects that the patient might be experiencing, starting from the symptom control. Communicating, how do we break bad news for these patients? Lucy has talked about how communication is given in piecemeal. Is it sexually, psychosocial care, education, and research? And next, and we look at some of these things that might affect our patient with a diagnosis of breast cancer. When we think of the word survivorship, we are looking at defining a survivor from condition. So survivorship starts from through treatment and cure. So from the time you have this diagnosis, there are many aspects that would affect how you balance your life, looking at the social, financial, sexual, psychological, intellectual, spiritual, and physical aspects. And all these components are key in terms of bringing survivorship together. And Lucy has also spoken to the need
Esther, are you still there?
being part of this care plan when we're looking at the whole management plan.
Esther, are you still on the call? We cannot hear you. It does appear like Esther has dropped off from the call again. We'll give it a minute, and if she's not able to rejoin, we will continue with the next speaker. In the meantime, as we are waiting, if you have any questions, please type them on the Q&A. We have people moderating the questions. Thank you. Esther, are you back? Dr. Muinga. Oh dear.
It's back. We can go to the next slide. We can go. Hello?
Yes.
Hello? Now it's back. Okay. I was talking about the survivorship plan. All right. When you're looking at the survivorship plan, our goal is to detect the treatable recurrences. So I mentioned survivorship. When you're looking at the plan, you're looking from the time of diagnosis. Discussing with your patient, they have a diagnosis of breast cancer. After treatment, during treatment, how do they report symptoms? Lucy talked about clinicians and time, giving time to patients to give their views. I have pain, how do I report it to my doctor? Are they able to give me medication or therapy that is necessary to manage my condition? Survivorship care plans also look at prevention of other conditions. So there might be, depending on the patient, there might be plans or individual plans set aside for you to continue with either surveillance just means looking out for other conditions, or just continuous regular plans in terms of a patient goals.
So Esther, we are having serious connectivity issues with Esther in terms of being able to be audible. And I'm suspecting, because also time was of essence, if we can have Deborah speaking to some of the issues that have been raised, and especially Deborah, if you can address the issue of financing on healthcare. Esther, we will come back to you as you look at maybe a different connectivity device, and so that we are all on the same page. It does appear to be quite dicey. But Deborah, over to you. Deborah, you on the call?
Yes, I'm
You're
on the
muted.
call.
If you could speak into financing breast cancer control in Kenya, as we are waiting for Esther to also sort out the connectivity issue. Over to you.
Thank you. Thank you so much for this opportunity. And it's also great listening to the previous fellow panelists. We've listened to Lucy, we've listened to Christine, and also Esther. And the voice actually articulates the challenges and the issues that the survivors and, the organizations that work with survivors are articulating concerning the issues that they're going through. So I'll briefly speak about financing for cancer, and also just to generally share with you where we are as concerns to the new Health Financing Act, or rather the new UHC acts that we have on board. So first is to acknowledge that financing for cancer control remains a challenge, not only to Africa, but many of our developing countries, especially the countries in sub-Saharan Africa. In view of that, we understand that the government of Kenya has been increasing spending and expenditure on cancers. We know the investments that the government has put in place, both from, financing of cancer management services, as well as building the infrastructure. We know the expansion of cancer centers, the regional chemotherapy centers, among others. We can speak of the investments that have been ongoing. And that is what resulted to what Njeri was talking about, that generally there has been some improvement in access, especially when it came to treatment, but also acknowledging that we have challenges in access to diagnostic services for cancer. But key to note is that out-of-pocket expenditures are still high, and this makes it worse for, conditions like cancer that results to negative impact in the household income and the catastrophic health expenditures. And we also understand it also comes with financial toxicity that brings about further treatment barriers to the already affected, households or persons. So looking at all that context of where we are coming from, recently the government enacted 4 acts. Namely, we have the Primary Healthcare Act 2023, we have the Social Insurance Act 2023, we have the Digital Health Act in 2023, and the Facility Improvement Acts of 2023. All these acts provide a legal framework that reinforce the health systems for effective and efficient delivery of health services to all persons, as just the way we described what UHC is, all persons based on their needs, not based on their ability to pay, not based on any other factor, but based on their need. And I think that is a commitment that is enshrined in our Constitution on the right to health, as well as achievement of universal health coverage to everyone. So in view of all that, and we know that we are working within constrained economic environment, the way these acts and the acts have come at a timely time, the way these acts are, I've already mentioned, it's for effective and efficient delivery within the, all the factors that we are working with. So allow me to describe these 3 acts and what it has for us as healthcare workers or survivors or policymakers within the healthcare, within cancer control. So 1, the Primary Healthcare Act, the main purpose is to promote the implementation of primary healthcare. We have been implementing primary healthcare for so long, but how do we make it, more efficient and effective? So the context of the acts are mainly how we systematically implement this act, and it also it also delineates the roles of all stakeholders and at all levels. Secondly, the Primary Healthcare Act also provides for the establishment. We know that PCNs, or the primary healthcare networks, are being established. This is a model that Kenya has adapted to work on it. So it provides for that. It also provides for establishment of community units and other stakeholder-centered engagement forums. And the end-term goal is sustainable provision of primary healthcare services. There's a lot of shift overall from curative to preventive and promotive approach, and that is why we have this, that is why this particular act emphasizes on it. The other thing key to mention is that the health system, one of the vision of the policy also is to be responsive to the needs of our population. So primary healthcare also reorganizes the PCN network. Probably I can just describe how a PCN network works. I'm sure we have a number of healthcare workers here, and some may have been already sensitized on PCNs. But in the PCN, it's a network, but that also includes both, private and public facilities. We have the hub, which will be like the level 4 facilities. We'll have the spokes, and we'll also have the communities. So the referral system along from the community to the hub is really emphasized, and there'll also be a multidisciplinary team that will be supporting the particular hub based on the needs that have been identified. So the other thing also to remember is that there's a lot of focus also of community service provision as well as community engagement through increased education and awareness about many conditions, including cancer symptoms and all that. So the other thing that will also be promoted in level 2 and 4, we know the community is level 1, level 2, 3, level 2, which are the dispensaries, level 3, which are the healthcare, which are the health centers, will also be part of it, and finally the level 4. In all these stages, there is a lot of emphasis for screening and early detection. Remember that when we invest any dollar we invest in non-communicable diseases has a 3-fold return for investment on the same. So basically, that is the Primary Healthcare Act. Then secondly, we have the Social Health Insurance Act, and I'll spend a little bit more time on this. The Social Insurance Act. This one provides the legal framework for improved health outcomes and financial protection in right to the right to health and universal health coverage. So we have a 1-year transition period. We are not going to have NHIF. We'll have a new authority that will be called a Social Health Authority, and it will be the one who are in charge of, of operationalization of this Social Health Insurance Act. Then secondly, the other purpose of this act is that it will provide access to health services and care for all. And this will also include vulnerable populations with no exclusions and no limitations. But remember, this is informed by the essential benefit package that is also informed by the Kenya Health Essential Benefit Package. So that's the other factor about it. Another thing is that it will consolidate all the schemes. We have so many schemes under NHIF. We have Linda Mama, we have Edu Afia, we have the civil service. We have so many schemes, and these schemes are fragmented, and that way the efficiency in management, we are not gaining on the efficiencies in management, and we need to consolidate them all into one. Because by the end of the day, it's about a household, it's about a person throughout their life cycles. So that's the other thing that the Social Health Insurance Act is going to do. Then the other thing is that the beneficiaries, the entitlements to beneficiaries will be based on the Essential Benefit Package. I've already spoken about that. And we'll have a household cover. And meanwhile, the processes of making regulations to ensure that we have this act effected are ongoing. So within the transition period, we'll have detailed regulations on how that's going to happen. So this act, the Social Health Insurance Act, is divided. It has 3 main funds. The first fund is called the Primary Healthcare Fund or the Afya Bora Fund. The Afya Bora Fund is mainly for direct provision of basic primary healthcare services, and it will also support direct purchasing of healthcare services from, let's say, the FBOs, and it also, look into how contracting of health services in the private sector will be done. So under the PHC fund, the Primary Healthcare Fund, this is where we have, we talked about the act. So we have the Primary Healthcare Act, which is separate, but we have its corresponding Primary Healthcare Fund sitting within the social health insurance. And in line with that, a lot of the health services that will be supported will be on screening, will be on early detection and early treatment, And speaking for cancer, those are the various phases of support that will be supported. The second fund will have a social health insurance fund. Yeah. This fund now will support from level 4 to 6. You remember Primary Healthcare Fund is mainly from level 1 up to level 3. So the Social Health Insurance Fund now will go into supporting, the investigations and treatment. For this instance, it's cancer investigation and treatments. Specifically, it will look at screening, it will look at radiological imaging services, the surgical services, the oncology radiotherapy, the oncology chemotherapy, and palliative care. These are among the services that will be provided under the Social Health Insurance Fund. And remember that is from level 4 to level 6. The third fund is the Chronic Critical Illness Emergency Fund. This will also be within level 4 to 6, and it will cover the cost of, chronic illnesses and events. For instance, we have chronic illnesses such as cancer, diabetes, strokes, pandemics, all that. So cancer is among the conditions that will be covered. So, but the main condition for access to this fund is once, a household or an individual has depleted the social insurance fund. Remember the social insurance fund. Once it is depleted, then this individual will be able to access the Chronic Critical Illness Emergency Fund. The other thing to note that it also will finance emergency services, including evacuations and all that. So that's all about the Social Health Insurance Act. And remember that under it, it's divided into 3 funds. So the next act that is also supports the health system and also supports, supports not only the health systems, but also the individuals and communities, is a Digital Health Act. The Digital Health Act, just like the others, it also provides a legal framework for electronic medical records and digitization of health services, And this is envisioned to enable access of health services from any health facility. We'll have unique identifiers of, clients or patients, and this will enable you, it will keep your records and enable you to access services, from anywhere, and someone can really access the history of, the conditions, what you've been on, the diagnostics you've undergone, all that. And this one will also enable real-time data availability. And the other good thing about it is that it will also promote the use of mobile platforms. With our mobile phones, we can be able to access health promotion, self-monitoring, capabilities within it. So through this, we'll be able to have, of course, increased awareness. We'll have clients who are empowered. It also enable, custody of your own records and data. And it will also enable, enable one to organize appointments, and also it will promote privacy and also enable us to gain trust within our health information systems. So the other capability of this act is that it's going to promote the use of technological innovations. For instance, let's say in cancer management, the cyber knives, you know, and it will also promote telemedicine to reduce the cost and also provide access. So the reason why I also included the Digital Health Act is that, you know, health systems work together. Health systems are systems. We can't talk about money alone when we don't have other factors addressed, you know. So digital is also increasing, you know, our efficiencies in managing information and also putting us in line with the ever-evolving technology. The fourth act is the Facility Improvement Act 2023. We know a number of counties have already enacted this act, and that's such a great thing for us. But this is now like an overall one. But under this act is that it's providing the legislative framework that enables at facility level to, you know, to retain the resources that are either collected or claimed. The facilities will be able to retain those resources, and they'll also be given an autonomy in decision-making, you know, decision-making so as to improve quality of service provision. We know in the past, funds that are collected at the facility level have been, you know, commingled together at the consolidated, you know, county funds. But now within the facility level, if the facility have identified their needs that they want to address, they can do that. But the main focus is to improve the quality of service and be responsive to the communities that they serve. So in essence, those are the acts I just wanted to highlight. Yeah, and probably I can just mention, so from where we are, how can the communities be cushioned? Now speaking to communities, but let's remember that the process of, you know, making the regulations towards operationalization of this act are ongoing. So we have 1 year transition period, but even within that, the social health insurance fund will be broader, you know, it will be based on equity, you know, you pay based on what you're able, you know, to give, but you'll be able to be cushioned against, you know, the various health needs that you may require. But we as communities, once it's operating, will encourage to register and enroll into it. We'll be encouraged, of course, to utilize the services that are there and also continue with advocacy for enrollment and also promote identification and onboarding of the informal sector. You know, a big chunk of the informal sector are not really enrolled even in the current NHIF. So we're looking forward to have, you know, to broaden the pool of financing to also dig also deeper also into the informal sector. And community are also encouraged to engage in information sharing forum and also social accountability initiatives. So probably, Brenda, I'll leave it at that, but we can engage further as questions arise. Thanks, and over.
Thank you so much. I want to bring back the conversation to Esther, but before I do, I think one of the things that we have to appreciate about our various speakers is the level of expertise they bring on the table. Jerry did ask about the diagnostics question and whether it is possible to get the access to diagnosis as early as possible so that we're not waiting for late stage disease for NHIF to pay. And from what I've heard from Deborah, is that we have the Primary Healthcare Act, and we also have the PHC fund that will take care of preventive health, that is health promotion and preventive health awareness education for people to be self-sensitive to disease as early as possible and to get minor treatments and ailments, treatment for minor ailments. And then there is the Social Health Insurance Fund, which is coming to bridge the gap on diagnostics, on screening, on imaging, on radiotherapy care, as well as any other cost that would require for especially NCDs and high cost of treatment. And lastly, we have the Chronic Care Fund, which would then take up, if you've exhausted the Primary Health Care Fund and you've exhausted the Social Health Insurance Fund, then the other Chronic Care Fund can plug in and ensure that you're not experiencing unnecessary toxicity in financing for healthcare. If I heard you correctly, Deborah, that's what you were speaking into.
Yes, you're very right, Brenda.
Fantastic. And so, Jerry, your questions have been answered in terms of information to patients, in terms of working with survivors as a linkage to get this information going, getting diagnostics as early as possible so that patients can access care. And now we come back to Esther Moinga. Esther, I hope you've gotten a better link so that you can take us through what was quite an interesting conversation on palliative care. And because then the one question we'll be posing back to the speakers and the panelists is palliative care part of what is covered in the PHC cover? So Esther, over to you. Thank you. Esther, you're muted. Oh dear. It would appear, Esther, you're muted. Kindly unmute and speak.
So apologies for the technical challenge from Esther's side. We are working on bringing her back.
Thank you. Thank you so
Thank
much,
you.
Nelson. Okay, Esther, go ahead.
Thank you. Thank you for the patience. We'll go right ahead from where I'd stopped. Just a highlight on what we look at, or what challenges patients experience as we're looking at someone with a serious health suffering or a diagnosis of breast cancer. Important to note that there could be physical, psychological, spiritual, or social needs. And some of the social needs have been highlighted by Deborah when we're looking at the financial burden experience, as well as the solutions out there for patients and families to take up. In terms of the physical aspects, you're looking at the symptoms, you're looking at things like pain. Patients might have lymphedema, patients might have appearance issues, also when you're looking at the psychosocial and social. And then spiritual, looking at issues of are they losing hope, meaning of life, looking at things about how patients perceive suffering and how they cope with that. So when you're looking at the holistic care of the patient, you're not just looking at the diagnosis of the primary diagnosis, but you're looking at the associated symptoms or effects that they may be facing. As we look at this, what challenges, what solutions are there to these challenges that you are experiencing? Next slide. We have documents that support provision of services or guides standardization and regulation of these services. The National Palliative Care Policy that was launched in 2021 provides a framework of care for patients and families living with palliative care needs. And there are 7 pillars, also looking at issues to do with survivorship, end-of-life care, advanced directives, and key populations. I saw a comment about assisted dying and how that comes into play. For Kenya, we don't advocate for that, and anything to do with euthanasia is actually not legal. But what we say is if a patient is receiving palliative care services where they are, you're looking at the 4 domains I talked about in the previous slide. The patient will not be suffering, meaning that they would have a better quality of life and they're able to cope with the illness or the situation at hand. So this policy also talks into the breast cancer action plan. We have the National Cancer Control Strategy, as well as the cancer policy, the Kenyan cancer policy that also gives a framework for provision of services. The policy does look at patients, families, communities, legal professionals, as well as the policy makers. As health professionals, there are also things we are able to do to improve our knowledge of palliative care service provision. Next slide. So the Ministry of Health has an e-learning platform that provides you with resources for people to learn and understand cancer care specifically, and you get certification. So this is a great milestone achieved through the Ministry of Health, as well as the National Cancer Control Program, where if you create an account and log into this elearning.health.go.ke, you're able to access resources that will help you take care of patients and their families in a better way. Another opportunity that's available to us is this opportunity to network with other palliative care providers. That's the Palliative Care Conference that's coming up in Kisumu County. So if you're available, feel free to join the other palliative care practitioners between 15th and 17th of November. That is in Acacia Premier Hotel. And finally, palliative care is basically about living. As we look at patients and as we look at the families and the people we support, either you as a caregiver, as a survivor, as a parent, as a sibling, as a health professional, the goal of care is looking at the improvement of quality of life. So we don't give up in palliative care. We support patients wherever, at whatever level they are. We meet them at that point. And in terms of ensuring that these strategies and guidelines are also enshrined in different human resource policies within organizations. I know there are organizations that have different policies talking about if a patient has this diagnosis of cancer, they become incapacitated, maybe they're not able to function to the level they were before. How do you support them as an organization? And I know these are different from organization to organization. So those are things we also need to think about as we are talking about palliative care and survivorship. How can we make sure that as we reintegrate patients into the community or into their workplace, how do we make this better for them? And how do we continue providing support in a way that is sustainable for all parties included? So thank you so much. That's the end of my talk.
Thank you so very much. I'm going to now open the floor. I've seen a number of questions. And Esther, I want to just appreciate what you've put across. And actually, if there was a way to send a chat, it's to send the chat on the e-learning platform, because some of the questions that are being asked and some of the questions that need further analysis can actually be found from the e-learning platform. And it's part of knowledge, learning together so that we can be able to be better advocates and better clinicians. So I'm going to now go into questions. We have just about 10 minutes in which to address all the topics that we've talked about today. And I can see we have a number of questions. The most pressing is that there is the CPD. I wrote an email concerning CPDs, but no response yet. Maybe Nelson, you can respond to the CPDs. And then I've seen Jerry, you have your hand up.
To respond to that after the Q&A. So just keep all of them and then I'll be able to answer.
Thank you. Lucy and Jerry, you have a question or you have an input to give.
Yes, thank you very much, Brenda. I think that we said it was amplifying the survivors' voices. I have some concerns to bring to the people, and maybe we look at them and see the different perspectives that we can use, or where we can start, or where we can stop, and see how we take this conversation up front. There is the stakeholders forum that has been mentioned. It is good that we have the essential drugs. Is this information available to the patients? I don't think our patients are informed, so as when they go to the clinics, they tell Daktari, among those three drugs you have subscribed for me, I know this one is essential. So still on the patient's information, there is a gap. Because I would love for people to go and say, I know my prescription is for 5 drugs, 2 are essential. So the only stress I have is for 3. So our people need to be educated, equipped, and when we go out there, we will be able to speak ourselves out about data on a health app. It's a good initiative, it's a good idea, I love it. But is it accessible to the patient? Because for me, the perspective that I look at it is that the central person here is the patient, the community, the patient, the doctor, the patient, the pharmaceutical company, the patient, the organization. We have one interest, the interest of the patient, so that we can change the health system and be a step in front. So I'm trying to think somebody who is in Kisii, Kakamega, in the interior of Kiambu, do they have will they be able to access the digital health app? I was tasked to get a gentleman for breast cancer month, and I got like 5, but all of them had kabambe. Now tell me, we wanted to bring the message out. They didn't even have a phone, and I requested, can you go to a cyber cafe? We send you the link so that you can join. Because for me, is the barriers are there, but for me is to look at ways where we can do away with the barriers. Go to the nearest shopping center. There is a cyber cafe. Send the link, then you get you that, and you get the information. And this person tells me, I even don't know how to operate such things. So when you talk of dental health app, we have a lot of homework to do, not for Lucy, but for the other Lucy's that are inside there in the village. When you talk about inclusivity, I always have questions. Policies are made, strategies are there, but they are for who? They are for who? If I've been not told, this is what we have for you, I might ask that, Lucy, if we remove the whole breast, how would you feel? I'm never asked. You are told that this is the best practice that will do for you, but they should regard and ask how I feel, because for us, it is physical pain and emotional pain. That is just one para point, and we need to look at this, and that's why I'm talking about feedback. So I know that I'm not a daktari, but we can look at that. And then something else before you hold me, overrated October. I was asking people, apart from putting on the pink t-shirt and the ribbons and posing, solidarity with cancer survivor, with patient, breast cancer month, what did we do? Did we tell those organizations, are those organizations that who are doing that, did they tell their employers, please, we facilitated screening for you this month, let's give you screening? Or we were just posing for the t-shirts and the ribbons? Did we tell our brothers and sisters, because breast cancer is for everybody, please go for screening? Did we do that? Or for us, we are just overrating pictures, pink. I think it's time we put action to what we are doing. Otherwise, tutazidi kunena pia, and the results ground ni tofauti. Thank you.
Thank you so much, Njeri. I think in response to some of the things you're raising, Njeri, and I want to come back as also not just as a moderator for this session, but also to say, as a team that has been working in advocacy for a long period of time, I think the advocacy community needs to sit down and take stock of where we are at, because there was a time all cancers were lumped up in October. And so when we spoke cancer awareness, it was always Breast Cancer Awareness Month is where all cancers are spoken about. One of the big changes I've seen in the advocacy space is that now we have more of focus on different months for different cancers. And that is bound to raise awareness and raise sensitivity to the issues at hand. The second thing that we also ought to take stock is what improvements have happened and how can then we take the same message and take it to the community. For example, Jerry, today you've raised the issue around equipping, educating survivors and caregivers as people who can go back to the community. Now that you've heard today that Herceptin is available as one of the drugs on the essential drugs list, and it is available to the patient, today, all cancer groups that you are in should also be made aware. And so that tomorrow when they go to the next step, to start asking for these services and they are not available, we can come back and advocate to ask, the services were said to be available, are they being made accessible to the patients? And so the onus is on all of us. I love what somebody said, and I think it was somebody who is close to you, Jerry, if not yourself, that advocacy haitaki uzembe, meaning advocacy takes hard work, and therefore we need to put in our best foot forward because we are all working towards the same goal. And that is, if information comes to you, pass it on to the others so that we can act on it. One of the questions that have been asked on the chat, Sophia Makuva has asked on survivorship, is there any legal document that can help safeguard your employment, especially where the employer is looking for reasons to render you redundant, even when you're trying to put your best foot forward? So maybe I'll ask both Deborah and Esther to speak into it, 1 minute each. And as you do so, kindly also offer your thoughts and what you've taken out from this session today. We only have 2 minutes to finish. We can start with you, Deborah.
Brenda, please come up. Please, pardon about the question.
On survivorship, is there a legal document that can help safeguard the patients to safeguard their employment?
Okay, about safeguarding of employment, I may not have a comprehensive understanding of what we are doing concerning cancer, but I know a lot of work has been done concerning HIV, and we have a HIV tribunal in place, and we have a lot of activism on, on both on employment and access and stigma and all that. And I believe that there are lessons in country that can be built upon as concerns to that. Then on the last points that you can mention is, one is that universal health coverage is achievable, even for cancer, but it is progressive, and we will work together, all of us together, to achieve this. And we are glad to have the social health insurance on board to finance the aspects that concerns social protection and also financial protection. Then secondly is that the legal mechanisms are great. I've seen a comment about centralization of this around health systems. I want to just mention that this is just not about the national government. It is acts of parliament. They are for all of us, and we are all to implement it. And a good example of an act that is coming down to all of us is the Facility Improvement Act. You collect the funds, you claim the funds, and you use them at your level, So it's not really about the national. Then secondly, we'll have regulations that will depend, and they'll go deeper into, prescribing how those acts will be implemented. So last but not least is that, of course, let's all invest in prevention and promotive health services to reduce, of course, the healthcare costs and also to improve the quality of life amongst our survivors. Thank you, and over to you.
Thank you. Thank you. Esther?
In addition to what Deborah has mentioned, the issues to do with employment because of illness is, I know the Kenyan Employment Act lists what benefits a staff is entitled to. But I know different organizations have also developed their own guidelines and regulations as to how they handle a very sick patient. Of course, there's the balance between the patient or the person staying employed and being unwell. I don't think there's a straightforward answer to that, but it's for employers also to be sensitive to the fact that even if someone is unwell, but they're still functional, there could be opportunities of empowering them to continue working or getting some form of work or financial support through the organization. Could be support with the health insurance or just them being given lighter duties for them to fulfill, also as they continue seeking treatment for the same. But maybe someone within the HR space would be able to answer. But in terms of being ethical and within the legal space, it would be unethical to summarily dismiss someone because they are sick and without any support towards them. In terms of my parting shot and my learnings, especially from what has been shared this afternoon, I'll also remember advocacy. Haitaki uzembe, that's true, because you still need to keep talking and sharing out there whatever information is available. But another key thing is involving patients and caregivers as being their own advocates for what they need. I may not know what my patient requires at point X, but for me as the caregiver or as a patient, being empowered, I'm sure there are many opportunities. And just going back to mentioning Benda's organization does empower survivors to become their own advocates, because it's not something they wake up knowing, but they learn also on the job, so that even as health professionals, as we take care of them, we know what is actually needed and not just being the ones who dictate what should be done. The last thing is we are all responsible for our health. If we can include aspects of prevention, screening, early detection and care, and then of course taking charge of our own insurance obligations. We have NHIF or SHIF coming up. If we can all become members of such things so that you're also cushioned when these things come along your way, it becomes better for all of us. Thank you so much, Benda, and thank you, Tip, for the opportunity.
Thank you. Christine, I'm coming to you because when we've spoken about even employment, and you mentioned KENCO has over 60 members right now. Are there some that are working on the legal approaches and human-based, rights-based approaches to cancer and advocacy? And so that then we can be able to send such a comment to such a team that would be able to assist. And Christine, you can also give your closing remarks. I'm begging everyone, we started 10 minutes late, so I'm actually watching the clock to say that we have just 5 more minutes if we can extend to that much. Christine, over to you.
Thank you very much, Benda, and thank you, co-speakers. So in terms of the legal framework in the country, we currently are working closely with pro bono legal officers or legal people who know about the legal aspects. And I know we have been receiving a lot of inquiries and a lot of concerns about patients and their legal rights. I know there's already what KEPCA has been doing in terms of legal rights for cancer patients. So I know that is one organization where patients would look into, but mostly, and I know a lot, they really support in terms of, the property, but there's much more that needs to be done, especially now with the workplaces. And that is why now as an organization, we are keen on introducing a conversation on safeguarding and having a safeguarding policy, a cancer safeguarding policies that workplaces could borrow and utilize as they work with cancer patients. So I would say it is work in progress, because indeed there is a big need out there, and it is very sad when patients have to lose jobs or go without
the opportunities, yet that is the time they badly need the money. I mean, we've all had cancer is really, it has a catastrophic form of expenditure. So it is work in progress, Brenda, and I hope in a couple of months we'll be saying that yes, we have a policy in place that can protect patients, and we look forward to one day having a landmark ruling in this country where a cancer patient's rights have actually been held. Now, my closing remarks, I would say cancer patients need support, and it is our work to encourage the general public out there. Each day, each moment, there's a new diagnosis that has taken place. We actually talk of 6 patients in every hour. So these new patients need to be given hope. And the ones who have not received their diagnosis and have no idea need to be educated to go for screening for the screenable cancers. So it is our work, all of us. We have a role to play, either in education or across the continuum to support the general public and those that are living with cancer. Thank you very much.
Thank you so much. And Jerry, last comment, not comments, Jerry.
Let me say thank you for the opportunity and the platform. Let me add that we need more time. I think 1.5 hours is very short, but now that we've begun the conversation, it should not end now. It should be all throughout. And let's make an impact where we can, a ripple impact. We can't change 100, but we can change 1. And that one will mean a lot. But an essential drug, somebody has written to me and asked me, if a patient is not able to access Herceptin, can we have a contact person for those people? And I've just told them that I'm going to ask here. So I know I'm in the TWG, I raised those questions in the Breast Cancer Committee, but now that it has been asked, let me ask here, do we have a contact person if somebody is not able to access Herceptin? Thank you very much.
Okay, so one of the questions that I'm taking from you, Jerry, is the linkage to care, and especially for that specific patient who has asked about accessing Herceptin. And what I will say is we'll take it upon ourselves and through KENCO to be able to get a listing of where those facilities they can be able to access and what is the recourse if they are not able to access it, so that we make sure that patients are getting what is rightfully theirs. My takeout from today, I just want to thank each one of you as the panelists, to thank the 600 plus participants that started today, and to thank the 519 who are still on the call, even though we've passed time. This is really a testament to the subject matter at hand, that we have a lot of work to do, and there is a lot of interest, and we all have a role to play. And so speaking about the roles we have to play, there is the government role. The government's role is to make policies, to make laws, to make systems that are serving people, and therefore to be able to give both access and affordability and availability for the services that are needed to maintain a healthy population that is meaningfully contributing to the economy. For the healthcare providers on the call, and for the government agencies on the call, and the clinicians on the call who are the deliverers of these services, we from the patients advocacy organizations also recognize that not only do we have the role of working with governments to make sure that these policies are implemented, but we also have the dual role of holding our communities accountable towards utilizing these services. And so that we are all working towards one goal: a healthy population free of cancer or free from hardship and financial toxicity that comes from cancer. And so as we finalize our call today on amplifying survivors' voices against breast cancer and against the platform of universal health coverage, my ask to all of us is, as we go back and we're reflecting on the things that we've taken today, we ask ourselves, what can I do in my own capacity, in my own space of work, in my own sphere of influence to ensure that, one, we're providing the services that are required, two, we are having laws and statutes that serve our people, right? 3, that we can be able to confidently see the health systems and the structures that we're putting in place. If we ourselves were the ones to utilize them, they would be able to serve us well. And lastly, to the survivor community, to the caregiving community, I like to think that we've done quite a bit and there is a lot of work to be done. One, because today is when the Social Health Insurance Fund has been broken down to the nitty-gritties for me by Deborah. And yet there are many people out there who are asking, do I need to register again? Do we need to start remitting 3 different funds? How will these monies be collected? How will they be taken care of? And so with all these questions coming to us, it is important that we look at it from a point of how will we continue this dialogue? As Njeri has said, October may be over, but the journey continues. How will we continue this conversation? And so live on air, I would like to ask Deborah, we will be calling on you again to do more awareness and more sensitization to our members, and so that we are able to take that message with authority and knowledge and with clarity and facts to the people who need to understand so that they can be able to implement. That is one of the asks. And of course, to thank all of you, to thank KNH for hosting us, Ministry of Health, through the Cancer Control Program for making this platform possible, and to thank each one of you for attending. For the CPD question, I think, do we have any representation from KNH? I'm not seeing anyone on the call now, but if we do, then they can be able to respond to the same. Thank you all for your time and many, many, many blessings. Brenda Kithaka from Kilele Health. We work with survivors, caregivers, and stakeholders to amplify the voice of survivors and to also ensure that we're bringing the voice of reason that cancer is not a death sentence. There is life beyond cancer. Thank you. Bye now. Yes, Yabesh, Josephine Yabesh. I'm not sure we're able to unmute you to speak. Yes, Josephine, you may speak now.
You're the host, Brenda.
Yes, you may speak, Josephine. You need to unmute and speak, Yabesh. And Janet Jepkoril. It does appear they're not able to speak. So thank you all for your time, and very, very, very impressed that we have so many people who have joined us today. We will continue with the dialogue. Thank you.
Thank you for the fantastic moderation. Bye.
Bye, and thank you, Christine.
Thank you all. Thank you, Brenda, and bye.
Thank you, Deborah. Bye-bye.